All right, everyone, welcome to ISGyP Live Journal Club. I'm your host, Natalie Benet. I'm an academic pathologist in Rhode Island, and I practice at Women and Infants Hospital, which is affiliated with the Warren Alpert School of Medicine at Brown Medical School. Today, I have a guest moderator assisting me, Dr. Kyle Devins, who is a GU and GYN Surgical Pathology Fellow at Mass General Hospital. After I do some brief introductory remarks, I will hand the mic over to him. For today's meeting, we will have brief remarks and introductions, then 3 presentations, which will each last approximately 12 minutes. After each presentation, we will have 2 questions via the polling function, where you as the audience will vote for the correct answer, followed by a few questions about each article if there is time. There will also be time for additional questions and discussion at the end of the presentation. Since this is a webinar format, you will not be able to unmute. However, you can use the question and answer function to put your questions in, which you can find at the bottom of your screen, indicated by the blue arrow there. It should be in the black bar. You can also upvote previously asked questions by pushing the thumbs up button to prioritize them for answering. And though there is a chat function, we ask that you don't use this for questions. You can feel free to use it for comments, which we will keep after the presentation. For those who may not be familiar, the International Society of GYN Pathologists was founded in 1976 for pathologists and other physicians around the world to share ideas and knowledge regarding the female reproductive tract. The organization offers a series of educational events known as ISGyP Live, including webinars, live slide sessions, podcasts, and this journal club. These events are available to all live. The journal club and podcasts are available to all in archived form, while the recordings of the webinars and slide sessions will be for ISGyP members only. For information about upcoming events and how to become a member, please go to isgyp.ca. These are examples of recent events, including the first live slide session by Dr. Joe Rabin on uterine mesenchymal tumors with deceptively bland morphology, an upcoming podcast featuring Drs. Lin Huang and Carlos Paraharan on genomic profiling of endocervical adenocarcinoma, and our second upcoming webinar featuring Dr. Robert Soslow discussing endometrial carcinomas and the use of histologic and molecular data to refine diagnosis and provide prognostically relevant information. The objectives of the ISGyP Live Journal Club are to engage trainees in gaining scientific knowledge and ability to critically evaluate the literature, to offer opportunities for trainees and young members from all parts of the globe to volunteer as presenters and moderators, to provide mentorship, and to engage the future leaders of our field from around the globe. The structure is of rotating topics which repeat every 12 months. So just one more quick reminder to upvote questions during the presentation that you would like to see answered or ask your own. And keep in mind that the questions are for trainees who are here to learn about the topic and critically evaluating the literature. We can continue the discussion on live on Twitter using the hashtag ISGypJC. And the materials from the Journal Club will be archived on this homepage here, including a video and the quiz material, which will be the polls asked after each question. Also, afterwards, you will be guided to an evaluation. You can click on that link when the Zoom webinar closes. We appreciate your opinions. And now I will hand it over to Kyle.
Thanks so much, Dr. Benet, and thanks to you and the ISGyP both for providing these learning opportunities for trainees such as myself and pathologists from all over the globe. And today we're going to be talking about uterine mesenchymal tumors. And other than smooth muscle tumors, mesenchymal tumors in the GYN tract are extremely varied and quite rare. So it can be hard to parse out differences between these neoplasms. Today we're going to be focusing mainly on how we've been using molecular genetic information to help us stratify and classify these neoplasms. With that, I'll introduce today's speakers. First speaking will be Dr. Amany Hassan. She's a lecturer of pathology at Mansoura University in Egypt. She'll be followed by Dr. Swati Bhardwaj, who is a PGY1 at Icahn School of Medicine at Mount Sinai. And Finally, we'll have Dr. Sharon Song, who is a Women's and Perinatal Pathology Fellow at the Brigham and Women's Hospital. And with that, let's get started. So Dr. Amany Hassan, I'll have you start sharing your screen.
Hello everyone. The article we are discussing today titled Uterine and Vaginal Sarcoma Resembling Fibrosarcoma, a clinicopathological and molecular analysis of 13 cases showing common NTRK-rearrangement and the description of a collagen 1 alpha-1 BDGF beta fusion novel to uterine neoplasm. It's published in Modern Pathology in 2019, authors from multiple institutions in UK, France, and USA. Malignant uterine mesenchymal neoplasm encompass a heterogeneous group of tumors with differing morphologies, immunophenotypes, and molecular alternations. The most common are leiomyosarcoma, endometrial stromal sarcoma, low and high grade, and undifferentiated uterine sarcoma. There are uncommon sarcomas occurring in the uterine body and the cervix, as rhabdomyosarcoma, angiosarcoma, malignant peripheral nerve sheath tumors, and others. In 2011, two of the authors co-authored in a report of a rare cervical tumor termed fibroblastic malignant peripheral nerve sheath tumor. This tumor was formed of spindle cells arranged in fascicular and story-form pattern and was positive for S100 and CD34. In 2018, there was another series of 4 cervical tumors that harbored NTRK fusions. These tumors resembling fibrosarcoma with breast mitotic activity, and the authors have noted that the endocervical fibroblastic malignant peripheral nerve sheath tumor have some morphologic and immunohistochemical resemblance to these neoplasms, and speculated that the former may represent NTRK fusion positive uterine sarcoma. So the authors in the study gathered the 13 cases of spindle cell sarcoma, 10 in the cervix, 2 in the corpus, and 1 in the vagina. Include the 3 cases of endocervical fibroblastic malignant peripheral nerve sheath tumor to investigate for NTRK fusion. All these cases had been diagnosed as a malignant peripheral nerve sheath tumor or undifferentiated sarcoma. All are composed of uniform cells and resembling fibrosarcoma. Cases of leiomyosarcoma, endometrial stromal sarcoma, and undifferentiated uterine sarcoma composed of pleomorphic cells were excluded from this study. They did targeted RNA sequencing, dual phage fusion, and array comparative genomic hybridization analysis, and immunohistochemistry for TRK antibody with variety of other immunohistochemical stains. They found that 7 cases harbored NTRK-rearrangement, 6 cases TBM3, NTRK1, and 1 case EML4 NTRK3. These cases were positive for TRK antibody. They found that 3 cases harbored the collagen 1 alpha-1 BDGF beta fusion. This molecular abnormality is characteristic of dermatofibrosarcoma protuberance and has not been reported in the uterine mesenchymal tumors before. CD34 was positive in these tumors and the TRK was negative. The last 3 tumors harbored no known rearrangement. They grouped the fibroblastic sarcoma in this study into 3 groups. The first group is the NTRK-rearranged sarcoma. All of these cases were located in the cervix, presented at younger age and earlier stage. The tumor borders were infiltrative. The tumor cells arranged mainly in patternless architecture, focal or diffuse herringbone architecture found in some cases. They are composed of spindle-shaped cells with ovoid nuclei in apparent nucleoli. Some cases show focal epithelioid morphology, cytoplasmic vacuolization. Some cases show scattered symplastic-like nuclei. Prominent lymphocytic infiltrate was found in 5 cases. The mitotic activity for this group ranges from 1 to 50 per 10 high power field, and the necrosis present in 4 cases. These tumors with the diffuse strong cytoplasmic positivity for TRK antibody, and was diffusely positive for S100 and CD34. Only 1 case was focal. Other markers, desmin ER, BR, BCOR were negative, cyclin G1 positive in 20 to 90% of the nuclei. They have simple genomic profiles without unbalanced intrachromosomal breaks, and all of these cases harbor cyclin-dependent kinase inhibitor 2A loss. The follow-up data for this group, 4 out of 6 cases were alive with no evidence of disease, and the 2 were alive with the disease. In one case, the follow-up data was not available. The second group is the collagen 1 alpha 1 BDGF beta rearranged sarcoma. There are 3 cases, 2 in the cervix and 1 in the uterine corpus, presented at older age. One case had a history of dermatofibrosarcoma protuberance at the back 1 year before the cervical tumor, and was completely excised with negative margin. So the authors thought that the cervical tumor is more independent of primary rather than mets from dermatofibrosarcoma. The borders were infiltrative. These tumors show diffuse, a prominent herringbone or storiform pattern composed of uniform spindle cells with ovoid nuclei and indistinct cell borders. The mitotic activity ranged from 8 to 20 mitosis per 10 high power field, and necrosis was present in 1 case. These tumors was diffusely positive for CD34. The fish show the orange-green fusion signals of the translocation. And the ER, BR Desmin S100 and the TRAC BCOR all are negative. 2 cases were analyzed for genomic profiles, revealed moderately rearranged profiles with unbalanced 1722 rearrangement and no cyclin-dependent kinase inhibitor 2A loss in this group. The follow-up data, 1 case was dead of disease after 60 months, 1 is alive with no disease, and 1 case is recent with no significant follow-up data. The last group, they termed the last group as fibroblastic sarcoma with features of malignant peripheral nerve sheath tumor. There are 3 cases. The first case in the cervix, formed of highly cellular spindle cell tumor. Focal lobular architecture is present, but otherwise infiltrative borders are found. They show moderate nuclear atypia with 10 mitosis per 10 high power field. They are diffusely positive for S100. However, SOX10 and Milan A was focal positive, but other melanoma markers was negative, and the molecular abnormalities commonly found in melanoma, recurrent KIT, PRAF, and NRAS mutations were negative. H3K27ME3 loss was focally positive. This group of tumors was more aggressive than the previous 2 groups. This tumor, in this case, it was recurred. The tumor recurred with peritoneal and pool mets after 6 months, and the patient is alive for 19 months later. The second case was in the uterine corpus, have the same morphology but more mitotic activity, 50 mitosis per 10 high power field, and the tumor cells show cytoplasmic vacuolization. S100 was focally positive, CD34 was diffusely positive, all other markers were negative, and H3K27ME3 was lost. Cyclin T1 positive in 90% of nuclei. This case was presented with mets to the adnexia and the abdomen at the time of the presentation and died 11 months later. The last case has a history of hysterectomy for benign reasons and was presented by a vaginal mass infiltrating the bladder and rectum. It has infiltrative growth with entrapment of adipose lobules and was formed of bland spindle-shaped cells with focal collection of ganglion-like cells. Has the low mitotic activity, 1 per 10 high power field, and show prominent lymphocytic infiltrate. It is diffusely positive for S100 like the other cases and negative for the other markers except cyclin G1 is positive. There is loss of the H3K27ME3. This case died of disease 34 months following surgery. In 2 of the cases, there is loss of the cyclin-dependent kinase inhibitor 2A. So the authors concluded that the uterine sarcoma with the morphology resembling fibrosarcoma after exclusion of leiomyosarcoma and the molecularly confirmed high-grade endometrial stromal sarcoma can be divided into 3 groups: the NTRK-rearranged group, the collagen 1 alpha 1 BTGF beta rearranged group, and the last group had neither of these molecular abnormalities, but on the basis of positive staining for S100 could be tentatively classified as a malignant peripheral nerve sheath tumor. However, additional molecular studies may identify specific genetic alternation that necessitate nomenclature change. The strengths of this study, the molecular analysis of the data, the description of a new entity, the proposed practical diagnostic algorithm, the follow-up data for the cases. However, large number of cases needed to be studied to expand the morphological spectrum and validate the IHC and molecular finding. The application of this article, first diagnostic application, they proposed a very helpful practical algorithm for spindle cell sarcoma of the uterus, composed of uniform population of cells. They included in this algorithm leiomyosarcoma, high-grade endometrial stromal sarcoma, and the three entities described in the article, with the addition of ciliary fibrous tumor, spindle cell melanoma, and inflammatory myofibroplastic tumor within the algorithm. And lastly, undifferentiated uterine sarcoma after exclusion of all these entities. This algorithm is very helpful when the typical IHC pattern is present. However, in some cases, there may be exception to the typical IHC pattern that require more differential diagnosis. Therapeutic application, the potential for targeted treatment in the first two groups, the TRK inhibitors and the imatinib for the second group. Area of future research, they recommended that more studies needed to be done on the role and the effect of cyclin-dependent kinase inhibitor 2A loss in intrafusion sarcoma and malignant peripheral nerve sheath tumor. Also, the evaluation of the specificity of the TRK IHC for NTRK-rearranged neoplasm. Xiang et al. Has found that out of 97 cases of leiomyosarcoma, 6 cases were positive for TRK antibody. 2 cases were diffusely positive and 4 cases were weakly positive. So further studies on large number of cases to identify the specificity of TRK IHC is recommended. Thank you.
Thanks so much, Amany. That was a great presentation. Thanks for condensing that data into a digestible format. Yeah, so for the first question, these COL1A PDGFB fusion sarcomas by immunohistochemistry were positive for CD34, and they were negative for ER-Desmond, TRK, and S100. And I think a big takeaway for all of the neoplasms mentioned here, those with the COL1A PDGFB fusions, those with the NTRK fusions, and those that were not found to have a fusion, they were all negative for smooth muscle markers. So, you know, these are rare tumors and many people may not have access to these advanced genetic tests, but something that can tip you off that you may be dealing with one of these tumors is the negativity for smooth muscle markers. For the second question, NTRK positive sarcomas in this study seem to arise in the cervix, and they seem to occur at an early age compared to the other tumors identified. The other clinically relevant point of the NTRK fusion sarcomas is that they're potentially targetable. No one has really examined this yet, but tyrosine kinase inhibitor therapy is used for other tumors with NTRK fusion. So there's a potential that they may have some efficacy if needed in these cases.
Okay. Hi. Hi, everyone. I'm Swati. I'm a first-year resident at the Icahn School of Medicine in Mount Sinai. Today, I'll be discussing this article titled Uterine Tumor Resembling Ovarian Sex Cord Stromal Tumors. It's a series of 3 cases with extensive rhabdoid differentiation, malignant behavior, and ESR1 and CoA2 fusions. The authors from this study are from 3 different institutions, that is University of Chicago, Massachusetts General Hospital, and the Cooper University Hospital. It was published in the American Journal of Surgical Pathology in 2020. So let's start with a little background about uterine tumors resembling ovarian sex cord tumors. These are rare mesenchymal neoplasms and have traditionally been hypothesized to arise from a multipotent cell in the myometrium. However, overall, their lineage still remains uncertain. And they are named so because they morphologically resemble the ovarian sex cord tumors. And even on immunohistochemistry, they show markers for epithelium, smooth muscle markers, and sex cord markers. Ultrastructurally, we can see both epithelial as well as sex cord-like differentiation in these tumors. So even though most of them behave in a benign manner, but there is a subset that is shown to metastasize as well as recur. That is why overall this entity is assigned an uncertain malignant potential, which means it's important to know that what are the features that can lead to an aggressive or a malignant behavior in these tumors. The previous studies have found an association between the presence of necrosis and a higher mitotic rate of greater than 2 per 10 high power fields as predictive of an aggressive behavior in these tumors. And the genetic studies that have been found out in this are the presence of GREB1 CTNNB1 fusion, GREB1 NCOA12 fusion, and ESR1 NCOA23 fusion genes. Of the tumors that have recurred in the past, all showed the presence of GREB1 fusions, but no ESR1 rearranged tumors have recurred before this study. So overall, there is little data on predicting malignant behavior or recurrences in these tumors. So this study answers the important question of what are the morphologic or genetic clues for predicting malignant behavior or recurrences in these tumors. And it is very important to know that, so that a recognition of these features can help us recommend long-term follow-up for these cases. So coming to the methods, at the University of Chicago, a case of recurrent uterine tumor resembling ovarian sex cord tumors was observed, which was composed entirely of rhabdoid cells. This prompted a search of archives, and they found 2 additional similar cases. They were also recurring tumors and also showed extensive rhabdoid differentiation. These cases were found at the Mass General Hospital and Cooper University Hospital. So this study describes these 3 cases, out of which for case 1 and case 2, both the primary as well as the recurring tumor slides were available. However, for case 3, only the recurring tumor slides were available. The authors reviewed the H&E slides and the immunohistochemistry slides from all these cases and reported immunohistochemistry as negative or focally positive if less than 50% and diffusely positive if greater than that. The formalin-fixed paraffin-embedded sections were used to extract RNA, which was subjected to RNA fusion next-generation sequencing at the University of Chicago. So now coming to the results, first let us see what were the clinicopathologic features in these cases. Case number 1 was a 37-year-old female. She presented with menometrorrhagia, underwent a hysterectomy that revealed the presence of a yellow-white myometrial mass, which was diagnosed variously at different institutions as an epithelioid leiomyosarcoma, endometrial stromal sarcoma with extensive rhabdoid differentiation, and a uterine tumor resembling ovarian sex cord tumor. This tumor recurred 7 years later as a pelvic mass and was diagnosed as a uterus with rhabdoid morphology. Case 2 was a 54-year-old female who presented with presumed uterine fibroids. She underwent a hysterectomy that revealed the presence of multiple red-brown myometrial soft nodules, which on histology showed the presence of a uterus, which recurred 9 years later as a pelvic mass. Case 3 was a 30-year-old patient, and there is no data on how the primary tumor presented. However, it was diagnosed as a uterine tumor resembling ovarian sex cord tumor. It recurred 32 years later as an omental mass, which was excised. 2 years after that, there was a second recurrence of the same tumor in the omentum. So now coming to the histological features of the primary tumors in cases 1 and 2. This figure shows that the primary tumor was highly infiltrative. We can see this bluish tumor mass infiltrating in between the muscle bundles and sort of splitting them. And there was a diffuse morphology, diffuse pattern of growth in some areas, and in some areas the typically chorded pattern of growth of sex cord tumors could be seen. In case 1, there were foci suspicious for lymphovascular invasion, but necrosis was notably absent in both the primary tumors, which in the past has been described as predictive of aggressive behavior. Mitoses were not appreciated in case 1, but in the primary of case 2, up to 4/10 high power field mitoses were observed. These are also pictures from the primary tumors in cases 1 and 2 that show a rhabdoid morphology of tumor cells. On the right in figure B, we can see the typical rhabdoid morphology with the abundant cytoplasm and the globoid and glassy nature of the cytoplasm. The nuclei are eccentrically placed with vesicular chromatin and prominent nucleoli. So this was the predominant rhabdoid morphology. However, the authors also observed these nuclear grooves, which are predictive of the sex cord-like morphology in these tumors. Now these are images from the recurrences in cases 1 and 2. Figure A is from case number 2, which apart from the regular tubular and chorded morphology, also showed the presence of these rare pseudoglands, which were absent in the primary, but were present in the recurrent tumor. And on the right, we can see a brisk mitotic rate that was observed in the recurrence of case 1, but not in the primary. So both the recurrences had a higher mitotic rate, and the primary only in case 2 had a high mitotic rate. These are images from the recurrence in case number 3. And there was both epithelioid morphology as well as 5% of the spindle cell morphology was also seen. There were areas of hyalinization also observed. The epithelioid cells, epithelioid morphology was both non-rhabdoid on the left as well as rhabdoid, as we can see on the right. Now, these are images from the first recurrence in case 3. The second recurrence in case 3 was composed entirely of rhabdoid cells. The immunohistochemistry results were similar in the primary and the recurrent tumors. The tumor cells were positive for WT1, ER, PR, CAM5.2, and CD56. Case 3, tumor cells were positive for calretinin desmin, focally positive for melan A and CD10. Notably, in all 3 tumors, INI1 and BRG1 was retained. The tumor cells were found to be negative for inhibin and SF1, that are more specific sex cord marker, and caldesmon and SMA. Now, these are the RNA sequencing results. So we can see on the left is the ESR1 exon, and on the right is the NCOA12 exon, and the 5' end, the 3' end of the ESR1 exon showed fusion with the 5' end of the NCOA2 exon, resulting in the presence of a fusion messenger RNA. This fusion messenger RNA had the N terminus of the estrogen receptor protein and the C terminus of the nuclear receptor co-activator protein. So these rare tumors were first described in 1976 by Clement and Scully, and the gene fusions that have been described in these tumors are ESR1 and NCOA23 and GREB1 and NCOA12. So ESR1 is basically the estrogen receptor protein that binds to the estrogen molecule, and the nuclear receptor co-activator mediates steroid sex hormone receptor pathways. The growth regulation by estrogen binding 1 protein is involved in the ER-ESR signaling pathways. Now, this is just a literature review of uterus in the past. The largest study was conducted by Drs. Moore and McCluggage, and they studied 26 tumors, and they found out an association between a higher mitotic rate that they defined as greater than 2/10 high power field and necrosis as predictive of an aggressive behavior. They defined an aggressive behavior as the presence of metastasis or recurrences. The other largest study was conducted by Dr. Goebel et al., and they found out only 1 tumor in their study that recurred, which showed GREB1 fusion, but had a lower mitotic rate of 1/10 high power field. Other than these 2, 15 tumors have shown a malignant behavior, but most of them did not show a high mitotic rate, as well as necrosis was absent. So rhabdoid differentiation has previously been described in uterine tumors resembling ovarian sex cord tumors. However, prominent rhabdoid morphology has been seen only in 3 cases in the past, only 1 of which showed the presence of ESR1 fusion. So whenever we see rhabdoid morphology, it is important to consider other differentials depending on the amount of rhabdoid morphology seen. We can see variable amounts of rhabdoid differentiation in undifferentiated endometrial carcinomas. However, these tumors have a diffuse growth pattern with uniform cytology. They do not have nuclear grooves as was seen in this case, and they have a brisk mitotic rate with frequent necrosis. We can also find variable amounts of rhabdoid morphology in picomas, but they have a nested pattern and they are positive for melanocytic markers. Leiomyosarcomas can also show a rhabdoid morphology, but they do have a spindled component along with that, with frequent mitosis and atypia. Carcinosarcoma can have rhabdoid cells, but they actually represent the rhabdomyoblasts, and it has an unequivocal high-grade carcinomatous component along with that. Endometrial stromal sarcomas can also show similar morphologic features, but they have small cells and they are CD10 positive. Now, when we consider the differential of tumors composed entirely of rhabdoid cells, there are only just 2 differentials. One is a recently described entity, that is SMARCA4 deficient undifferentiated uterine sarcoma. This tumor has a brisk mitotic rate with necrosis, shows loss of BRG1 and is keratin negative. Malignant rhabdoid tumors are typically described in the kidneys and central nervous system. They occur in infants and young children, and they show INI1 mutations. So overall, it's a very good study because it's the first study to highlight an association between uterine tumors resembling ovarian sex cord tumors with extensive rhabdoid differentiation, ESR1, NCOA2 fusions, and an aggressive behavior. But the number of cases studied were just 3, which is probably because these are very rare tumors and recurrences are even rarer. But if we increase the number of cases studied, then there can be, the results found out by the authors can be validated. This study has important clinical applications because we come to know of important morphologic features and genetic features, and recognition of these can prompt long-term follow-up to detect the typically late recurrences. So in this study, all the recurrences occurred one occurred at 7 years, the other at 9 years, and the third one at 32 years, which is very different from that has been described in the past. The mean time of recurrence in the past has been just 2 years. Therefore, it becomes important to follow up cases with these features for a longer term. That's it.
Thanks so much, Dr. Bhardwaj. That was a great summary of this paper. And okay, there we go. And you should see the answers popped up on your screen now. Looks like folks were right on once again with these answers. So for the first question, which of the following is true about Utrosk? They've been shown to have fusions involving GREB1 and ESR1, as was nicely highlighted in this presentation. And for question number 2, in this particular study, the rhabdoid differentiation, all of the cases with rhabdoid differentiation were seen in the ESR1 and NCOA2 fusions. And I think the study is a great example of why we need to collaborate with tumors that are this rare. For example, earlier studies had noted recurrence with GREB1 fusion Utrosks, but not with ESR fusion tumors. And again, the time to recurrence there and the time for follow-up was about 2 years. But here we see with longer follow-up, we note that there are recurrences in ESR1 fusion tumors, but sometimes very late. In fact, that one case of 32 years, extremely long time of follow-up needed for us to just be able to detect that risk of recurrence. So as time passes and we see more of these tumors, we'll expect to see potentially changes to our expected behavior for these tumors. And it's also useful to know, and Dr. Bhardwaj did a great job of parsing out your differential diagnosis when you see rhabdoid differentiation in these tumors, but being able to connect a specific morphologic feature with a specific genetic abnormality can be very useful, especially when you may be operating in a setting where it's not possible for you to do these specific molecular tests. Make sure we can get through everyone. I'm going to ask Dr. Sharon Song to share her screen and get going with her presentation.
Hi, everybody. My name is Sharon Song. I'm currently a Women's and Perinatal Pathology Fellow at Brigham and Women's Hospital. And the article that I'm going to be discussing today is called Genomic Profiling of BCOR-rearranged Uterine Sarcomas, Reveals Novel Gene Fusion Partners, Frequent CDK4 Amplification, and CDKN2A Loss. This is an article that was published by Douglas Lin and his co-authors. It came out earlier this year in Gynecologic Oncology. So before we dive into the article, I wanted to do a quick review of the classification scheme of endometrial stromal tumors. This is a family of tumors that includes the low-grade spectrum of tumors as well as the high-grade. So the low-grade spectrum of tumors includes your endometrial stromal nodules and your low-grade endometrial stromal sarcomas. And the high-grade spectrum includes high-grade endometrial stromal sarcomas and the undifferentiated uterine sarcomas. Given the topic today, I'm just going to focus on the high-grade ESSs. And presently, we subdivide these into 2 categories based on their defining molecular alteration. So we have our high-grade ESSs with YHNA-M2AB gene rearrangements, and we also have our high-grade ESSs with BCOR alterations. Now, focusing our discussion on the BCOR alterations, there are 2 that we know a lot about, and those are the ones with ZC3H7B BCOR fusion, which is by and large the more common fusion that we see, and then also the BCOR internal tandem duplication. So that said, the study aims of this project was to look at the molecular landscape of BCOR-rearranged ESSs, what other BCOR-associated alterations are there other than the 2 that we know about, 2 was to identify the novel BCOR fusion gene partners in ESSs and correlate these with their clinicopathologic characteristics, see if any new trends or patterns emerge. And then 3 was to identify potential targetable genomic alterations in BCOR mutated ESSs for therapeutic purposes. So how did they put their cohort together? This was a study that took place at Foundation Medicine, which is a reference molecular lab based here in Cambridge, Massachusetts. They did a retrospective search into their molecular database, and they looked for uterine sarcomas with BCOR gene rearrangements or BCOR ITDs. And these were all cases that have been previously assayed by comprehensive genomic profiling via next generation sequencing during the time of clinical care of the patients. So once they identified these cases, they looked at the clinicopathologic data on these patients. They gleaned this information from reports and synoptic reports, and they looked at patient age, tumor stage, and metastatic sites. And they also reevaluated the H&E slides that had been originally submitted for genomic profiling, 1, to confirm the diagnosis, and then 2, to assess the morphology and see if any unique distinctive morphologic features could be recognized. So here are the results, starting with the clinicopathologic features. Over a 9-year period, they identified 40 uterine sarcoma cases with BCOR gene rearrangements. And overall, this constituted only 3% of the overall uterine sarcoma cohort. In terms of diagnoses that these cases came with from the outside hospital, the 40 cases consisted of 22 endometrial stromal sarcomas, 9 undifferentiated uterine sarcomas, 8 myxoid leiomyosarcomas, and then 1 recurrent uterine sarcoma case that originally came from a uterine adenosarcoma with sarcomatous overgrowth. Now, interestingly, the 8 cases that have been called myxoid leiomyosarcomas, on re-review of the histology, these ended up being reclassified as BCOR-rearranged ESSs. And this was based on the morphology of the tumor, as well as the absence of known driver mutations that are typically associated with conventional leiomyosarcomas and also myxoid leiomyosarcoma. So this brings up an important point, which is that these BCOR-altered tumors frequently mimic myxoid leiomyosarcomas, and that is a potential pitfall to avoid. In terms of age, the median age of these patients was 54. On the whole, these are high-stage tumors. 70% of the patients presented with stage 3 or stage 4, and at least 18% presented with lymph node mets, although this is probably an underestimation given that a lot of the cases did not sample lymph nodes. The group did look at whether there were differences in age or tumor stage between cases with the common ZC3H7B BCOR fusion versus those with novel gene partners, and there were no significant differences. These are badly behaving tumors. They frequently spread to extrauterine sites, so sites include other GYN tract locations such as the ovary, the fallopian tube, sites within the abdomen, including colon, small intestine, omentum, lung and pleura, and then also bone. Here's an image showing that the most common gene rearrangement partner associated with BCOR was ZC3H7B, either as ZC3H7B BCOR fusion or the reciprocal. And this was seen in 78% of the cases. In terms of the histology that is seen with tumors with the common ZC3H7B BCOR fusion, typically these tumors are uniform. They have a spindled cell morphology with a predominant vesicular growth pattern. And in terms of the background stroma, they can have myxoid change or these collagenous stromal changes. So this is in keeping with a translocation tumor, just a very uniform appearance. And you can see based on these features why a myxoid leiomyosarcoma might enter the differential. Here's a snapshot showing the other novel BCOR gene rearrangement partners. So they're all listed here. These constitute about 20% of the cases, and they're all circled here in orange. So we'll quickly review the morphology of these tumors. Here's a table summarizing the morphologic features. So in general, the tumors showed mild to moderate atypia, but there was a subset that shows severe atypia. Nuclei on the whole, in about 90% of the cases, was uniform, again, in keeping with a translocation tumor. The predominant cell type was spindle cells, although there were a subset of cases that also showed a small round cell morphology and also an epithelioid cell morphology. And then in terms of the background, a subset of these had a collagenous fibrotic background. About 2/3 showed necrosis. Myxoid stroma was present in almost 90% of the cases. Mitoses ranged from 3 to 30, and then a prominent spiral arterial component was seen in a little over half of the cases. So here are some images to showcase those morphologic features. So again, spindle cells were the predominating cell component, but a subset also had this small round cell morphology. A subset also had this hypocellular fibromyxoid spindle cell component. And in this particular case, you can see the small round cell component sharply transitioning to the hypocellular myxoid areas. There was a subset that had a more epithelioid cell morphology with clear cytoplasm. Some of these tumors were quite hypercellular. Some showed this variably prominent myxoid background. And then a subset had a very prominent small arteriolar component to them. And then here's a case with a BCOR-rearranged fusion that showed a little bit of everything. So it had this broad front type of invasive growth pattern at the leading edge of the tumor. There were parts of the tumor that were quite cellular, particularly around the blood vessels, and it was sharply transitioned to these hypocellular myxoid areas, more distant from the blood vessels. There were spindle cell growth showing a fascicular growth pattern, but then elsewhere there was also this epithelioid cell component with a clear cytoplasm, and the background showed myxoid stroma as well as these collagenous plaques. So a lot of intratumoral heterogeneity as well as intertumoral heterogeneity in these tumors. Here's an oncoprint showing all the genomic alterations in this cohort. So there was high frequency of gene amplification of MDM2, FRS2, CDK4. Here's your respective percentages. Of note, MDM2 gene amplification, CDK4 gene amplification, these are only seen in the BCOR-rearranged high-grade ESSs, not the BCOR-ITDs. Also, the CDK4 gene amplification appeared to occur only in cases with the common ZC3H7B BCOR fusions and not those with the novel gene partners. There was also high frequency of homozygous deletion of CDKN2A and CDKN2B. And then when they looked to see whether this was specific to the BCOR-rearranged high-grade ESSs, it was not. It was also seen in 20% of the high-grade ESSs with BCOR-ITDs. Of note, the gene amplification of CDK4 and the homozygous loss of CDKN2A, these appear to be mutually exclusive events, and they signify frequent activation of the cyclin D CDK4 axis, which we'll revisit momentarily. So what are the main takeaways here? One point is that uterine sarcomas with these novel BCOR-rearrangements show more heterogeneous morphology than those with the ZC3H7B BCOR fusion. So in addition to that spindle morphology with the fibromyxoid component, you might also see a mixed component of epithelioid and small round cell morphology, varying degrees of fascicular growth, varying degrees of myxoid or collagenous stroma. So it's just important to keep in mind that these tumors can show a fair bit of morphologic heterogeneity, and just to keep it in mind for your differential. And does this matter clinically? We've expanded the morphologic spectrum, we've expanded the genomic spectrum of these tumors, but how is this relevant? You know, the study showed that in terms of behavior, there is no difference between sarcomas with the common ZC3H7B BCOR fusion versus those with the novel gene rearrangements. All of these BCOR altered sarcomas are aggressive. But what about treatment? So that brings us to the next point, which is that high-grade ESSs are often refractory to conventional chemotherapy, which is why these patients often have progressive and very advanced disease. So in the setting of failure to conventional chemotherapy, is there room for therapy with novel agents? And that's where this finding of frequent activation of cyclin D CDK4 axis comes in. So this axis is illustrated here on the right. This is the cyclin D CDK4 pathway, and you can see that when you activate this pathway, the downstream effect of that is continued progression through the cell cycle, ultimately leading to neoplastic proliferation. And so if we're able to inhibit this pathway, like in here on the left, through CDK inhibitors. The downstream effect of that would be a transcriptional block. And so we do actually have CDK4 inhibitors currently. And so there's a possibility that would need to be further evaluated through clinical trials about whether we can improve our treatment options for patients with these other BCOR alterations. So with that, I'd like to thank you all for your attention, and I'll hand it over back to Kyle.
Thanks, Dr. Song. Great presentation. As always, that's my former co-chief resident at the University of Pennsylvania. So let's see. Okay, well, excellent. Everyone's been right on today. So for which of the following is true about BCOR altered uterine sarcomas? They've been provisionally classified as high-grade ESS, and that is because based on most of the studies we have so far, they track similarly to the high-grade ESS with the characterized YWHAE fusions, which is a chance of recurrence and metastasis somewhere between low-grade ESS and undifferentiated sarcomas. And then for our second question, which was the following was noted in this cohort of cases, the point was that there were novel fusions, novel BCOR-rearrangement partners identified, and novel morphologies identified with those cases. And this was an interesting study in that it was initiated by Foundation Medicine, which is a reference laboratory, rather than, I suppose, the traditional method of these case studies where it's organized by an academic institution. And that comes with a few advantages and a few biases in this particular case. First off, I guess, biases. So typically, or for all of these tumors, they had to be sent for sequencing to be included in the study. And that is preferentially done on tumors that are high stage and aggressive. As you could see from what Dr. Song was sharing, most of these tumors were stage 2 or higher. And as a result, most of them were quite aggressive. But it does allow for examining tumors between different diagnoses. The submitting diagnosis was different for many of these tumors, but they were found to have a unifying genetic alteration and were subsequently reclassified. So it does offer a unique opportunity to reclassify tumors and to sample from a large portion of referral institutions because these tumors are very rare. So they were able to get quite a nice sample size in this study. With that, let's do a few question and answers. I'll have my presenters, if you're still on, feel free to pop back on with your mic and answer if you get a chance. The first question I'm seeing is for Dr. Hassan, and it's in regards to one patient with the COL1A PDGFB fusion uterine sarcomas did have a dermatofibrosarcoma protuberans reported as well. And the questioner is asking, how can we be sure that those aren't related? Do you want to take a stab at that particular question?
The authors didn't say they are sure they are not related, but they believe that it's most likely to be independent because the previous tumor was completely excised with negative margin, no local recurrence, no fibrosarcomatous transformation. Usually dermatofibrosarcoma meets preceded by multiple local recurrence. So they believe this is more likely to be independent, but not sure, of course.
Yeah.
Perfect, thanks. Yeah, perfect answer. No way you can be totally sure in those cases, but you know, we make the best guess we have with the information we have available. But it is interesting that there was a DFSP noted about a year, I think, before that uterine sarcoma was found. Otherwise, feel free to continue to and put in questions, by the way. We only have a few, we only have a small amount of time left. Another question about the UTROSC series, asking if the omental recurrence should instead be considered a true metastasis. I suppose, Dr. Bhardwaj, feel free to step in on this if you'd like. I think in many cases for GYN tumors, we treat pelvic and abdominal recurrence / metastasis. I feel like that word is sometimes used to mean similar things, but usually when we're talking about true metastasis for GYN tumors, we're thinking of something that has for sure spread through a lymphatic or arterial system rather than through cells floating or residually located within the pelvic and abdominal peritoneal cavities. So that may be why that wording was used in that case.
Also, Dr. Bhardwaj, what was the time interval between those two? Wasn't it like 20 years?
32 years. I was just about to say that, but it was like 32 years after the primary tumor. So I think it's unlikely to be a metastasis because they are separated in time.
Certainly. Certainly if they presented at the same time, you know, then you would think of it more as a metastasis. But 32 years. I'm amazed that the same place was able to review any of these cases together when they were so far apart. A lot of times people don't even save slides that long. So that was impressive to me. Yeah. Oh, there's another question now.
Third one, yeah.
Thank you for that question. Someone wants to hire all of you to come work with them. So just contact me for information about that. So there's, oh, go ahead. Dr. Paraharan, would you like to ask a question?
No, just jumping to say there was another question. It's an interesting thought about saying that someone bringing up the fact that there may be a group trying to, or proposing that we categorize those GREB1 fused sarcomas differently or separately from the uterus category. What do you guys think?
I read about that other category. Basically, they show a different fusion. I mean, the exon that it fuses with is, first of all, the genetic fusion is different in that category of sarcomas. It is not exon 14, it is some other exon that it fuses to. And also in those tumors that they call GREB1 sarcomas, in that study, they did not have a typical sex cord morphology. There was only one of those tumors that showed focal sex cord-like morphology. So I think it's different in that way.
Thanks, great answer. I feel like that question comes up quite often when we start trying to group things together by genetic alteration rather than clinical and morphology, but you make great points there.
Yeah, which is another point they bring up in Dr. Song's paper that you talked about, especially with a place like Foundation. They find these molecular transformations, and now there are clinical trials based on molecular findings, not based on tumor type, right? So when I think it's tempting for a lot of people to say, why bother doing these expensive, you know, rigorous searches for these esoteric genes? And the answer is that patients can go on clinical trials that they couldn't 10 years ago, especially in these rare cancers. And I think that's an overall theme of today. Dr. Devins was instrumental in picking these articles, and they are all very interesting, but something that is common among all of them is these are rare tumors. And so to study a rare tumor, you have to either be at a giant academic center where you're getting things sent to you from all over, or you have to be at a place like Foundation where people are sending you their rare tumors. I mean, imagine being able to search for BCOR abnormal tumors in a giant database and having 40 of them pop out. That's not nothing. That's a lot of these tumors. They're very rare. So that's very interesting. And I think there was another question in the chat.
The last question.
Yeah, so this would be for Dr. Song. Do you want to ask it, Kyle, since you're being the MC?
Yeah, certainly. Yeah. So the questioner is asking, when we look at low-grade ESS, actually it looks like high-grade BCOR sarcoma without molecular studies, mitotic activity can help us for the differential. So they're asking about how do you separate BCOR fusion sarcomas from low-grade ESS?
Yeah, you know, I think if you don't have the advantage of molecular studies to help you in honing the differential, I think you can rely on our morphologic cues, not just mitotic activity, but also the presence of necrosis, which was seen in a lot of the cases, lymphovascular invasion, which may or may not be helpful, but the pattern of invasion, if there is nodal invasion, nodal involvement. It was speculated that it was probably higher than what was seen in the study, but at least 18% did show lymph node mets. So I think just relying on our morphologic cues to suggest that the behavior of the tumor might be high grade might be a key to think about these BCOR tumors. Also seeing that round cell component or the epithelioid cell component that wouldn't be typically seen in a low grade ESS.
Great, Sharon, thank you. And with that, I think we're getting to just about time, although we do have a couple more questions. What do you think, Dr. Benet?
You want to do one more, and then we'll
let's
hang it up?
Let's do one more question. Oh, we're at, so IHC add-on to, I think, that last point, asking about SAT-B2 and WT1. I'm not sure if that is focused on the previous differential we were just discussing with low-grade ESS and BCOR, or if that's related to a different.
Yeah, it's not an extensively worded question, so it's kind of hard to tell which one they're referencing. But we can go ahead and
there's one more point that I think actually brings up a good point. So BCOR or cyclin D1 IHC. So that can be helpful, but I think it's important to keep in mind that with previous studies, BCOR IHC, it's not specific for the fusion. And in fact, in some studies, the YWHAE fusion high-grade ESS was more frequently positive than the BCOR-rearranged ESS. Yeah. So you have to kind of take that with a grain of salt, but the morphology is different. Remember, high-grade ESS with the YWHAE fusions, they have a mixture of spindled and also more epithelioid high-grade looking cells. So the morphology does look different. And also the fascicular areas and myxoid type differentiation, as Sharon was saying, those things can push you more towards a BCOR tumor.
Yeah,
and they look, the BCOR look very uniform otherwise.
And I think the comment referred to the particular differential of a low-grade ESS versus a high-grade, right? If you do the BCOR IHC, yes, like it won't tell you it's particularly a BCOR-rearranged sarcoma, but BCOR tends, at least in the small studies that we've seen, BCOR IHC tends to be negative in the low-grade category.
Right.
Good point.
Yeah, and that's the thing about the IHCs, like the BCOR and the NTRK, the IHCs. At first they're very specific, and then more people start studying, and people are coming out now with TRK positive, non sort of fibrosarcomatous tumors. So you just have to be careful when you're doing those to use everything all together and not just one marker. Yeah. Thank you to all of our panelists, everyone, for coming. This was lovely, and you all did very well, and I really appreciate it. And next month's topic is serous tumors of the ovary. I think I'm almost full for presenters, but if you would like to present, just get in touch with me. Thanks for coming. And follow the evaluation at the end. Thanks, everyone.
Thank you.